Great. Well, welcome everybody. We're at the top of the hour, so we're going to get started. We're so glad that you're all here with us today. My name is Stacy Chazen, and I am Director of Education and Leadership Programs for the American Institute of Dental Public Health. And it's my pleasure to be the facilitator for today's call. And if you'll take us to the next screen, we are going to review the learning objectives. Nope, flipping back a little bit. Okay, today we are very fortunate to be joined by Dr. Tim Ricks, who is going to be sharing a presentation with us in the didactic portion of today's call. I'm going to introduce Dr. Ricks now and then walk us through some housekeeping items. Rear Admiral Timothy Ricks served as the 20th Chief Dental Officer of the U.S. Public Health Service, as well as Assistant Surgeon General from 2018 to 2022. Dr. Ricks served in the U.S. Public Health Service for over 23 years as a clinician and an administrator, and over 35 years of total federal service, including military service. He currently serves in various roles in the Indian Health Service, including as the IHS representative to the Healthy People 2030 Oral Health Work Group, Continuing Dental Health Education Coordinator, Expanded Function Dental Health Assistant Coordinator, IHS National Oral Health Surveillance Coordinator, and National Oral Health Promotion Disease Prevention Coordinator. Welcome, Dr. Ricks, and we're going to turn back to you shortly. Next slide, please. The learning objectives for today's call are to explain the connection between oral health and chronic conditions and how it is impacted by disparities faced by those who've served in the uniformed services. Evaluate the benefits of a whole person integrated healthcare approach for veterans with those conditions. Evaluate the potential benefits and challenges of medical dental integration for veterans with heart disease and/or diabetes, and consider strategies to implement medical dental integration for veterans with heart disease and/or diabetes in clinical settings. And this is our presenter's disclosure. Thank you. Some quick housekeeping items. Today's session is being recorded and the link will be shared on the AIDPH website following today's call. We're going to be having a presentation and also engaging in interactive learning. And for those various pieces, we're going to ask you to either, for the presentation part of today's call, to stay on mute. And then when we enter the interactive portion, we'll invite folks to take themselves off of mute. We ask that you please add your personal pronouns to your Zoom screen name. And as we'll go over shortly, continuing education credits are available for today's call. So giving you an overview here of the CareQuest Institute for Oral Health. CareQuest Institute for Oral Health is a national nonprofit that is anchored in a better system of oral health that is accessible, equitable, and integrated for everyone. Over the years, CareQuest's partnership with AIDPH has helped CareQuest to put a spotlight on improving access and equity to oral health for veterans. And AIDPH is thrilled to have CareQuest as a partner in this Veteran Oral Health Action Collaborative. Next slide. And here's an overview of CareQuest's More Care model, which is what the VOHAC program is based in. More Care drives medical dental integration by collaborating with partners to build and strengthen local interprofessional oral health networks through integration and coordination of oral health within primary care. Through the More Care framework and curriculum, the ultimate goal is to improve patients' oral and overall health outcomes. And thank you to my colleague Liz Flannery for posting more information about More Care in the chat. Next slide. So about us at AIDPH. AIDPH has a vision of an equity-oriented oral health workforce that is prepared to lead. Our mission is to foster professional excellence and advance innovation in the education and practice of dental public health, which we do for 4 communities of focus: individuals living in rural areas, veterans, the LGBTQIA+ community, and individuals with disabilities. Next slide, please. So for those of you who are new to this group, who missed our introductory call, or even those who might need a refresher, we're sharing an overview of the Veteran Oral Health Action Collaborative, or VOHAC as we call it. VOHAC includes monthly seminars that are focused on health system transformation in the context of veteran oral health. As I referred to, each session includes interactive applied learning where we're going to tap into case-based concepts and turn to you, our participants, to create personalized action plans during peer learning sessions of the call. This is also a certificate program. So when you complete these call sessions, you have the opportunity to complete a competency evaluation, which will let you work toward certificate recognition for completing a certain number of calls and successfully completing the quizzes. And then everyone has an opportunity to earn continuing education credits for each call in which they take part. Next slide. So elements supporting integration within the veteran oral health landscape that we're going to be highlighting throughout the VOHAC series are shared responsibility for the oral systemic connection, establishment and use of a referral network, transitioning care models, an environment of improvement, and the use of health information technologies, all of which support integration. And our intent for this program are that outcomes will include increased knowledge and capability among participants to apply integrated and value-based care concepts in a clinical environment, a tailored education and application plan that benefits individuals and their organizations, improved quality of care for veterans, which we know are a high-risk, high-cost population, and a peer network to rely on for ongoing conversation and connection, both during the course of VOHAC and beyond. So as I mentioned, you all have the opportunity to earn continuing education units by completing an evaluation after each session. We'll post a link to that quiz for this session at the end of today's call, and it will also be available to you following. If you successfully complete a competency quiz for 6 of our sessions, either live or recorded, you'll be able to earn a certificate in integrated care approaches to veteran oral health. And any organization that has 2 or more individuals earning that certificate will itself, as an organization, earn a certificate of commitment to excellence in veteran oral health. And please reach out to us with any questions about these opportunities. Before I turn it over to Dr. Ricks, I will ask folks to please hold their questions until after Dr. Ricks is finished speaking. You can feel free to use the chat to post your questions. He'll answer those at the end. We are fortunate to have such a large group of folks with us today, so we want to be able to manage that Q&A process, and we will certainly have time for that. So that said, Dr. Ricks, I'm going to turn it over to you.
Thank you, Stacy, and good morning, good afternoon, everyone. It's an honor to be here for this VOHAC session. I'm going to talk specifically about chronic disease in veterans, highlighting some of the disparities that we see. Next slide. So this slide shows the dark is veterans, the light color is non-veterans, and this is looking at the percentage of men and women 25 and over with multiple chronic conditions. And as you can see, if you look at men, the first bar there, veterans have twice the number of, or twice as many veterans have multiple chronic conditions compared to non-veterans. And with women, it's also higher in veterans with multiple chronic conditions. Next slide. So if we look at some specific health disparities, and we're going to break this into men and women because we have data on both. On the left, you see men, and men compared to non-veterans, veterans have a 21% higher rate of hypertension in ages 25 to 64, 53% higher rate of stroke in that same age group, 69% higher rate of arthritis, which typically is an older person condition, and chronic obstructive pulmonary disease in that age group, 28% higher. Coronary heart disease in older seniors, 65 and older, 14% higher rate, cancer 25%, and COPD in the seniors 22% higher. In women, compared to non-veterans, women veterans have a 46% higher prevalence of arthritis in that 25 to 64-year-old age group. And in seniors, a 13% higher rate or prevalence in hypertension, 14% arthritis, 73% in asthma, and 42% in COPD. So you see some similarities with arthritis, COPD, and so forth. Next slide, please. So why do we talk about hypertension, and what's, most of us know the relationship between diabetes and COPD and things like that, but hypertension actually affects oral health. So poor oral health may interfere with blood pressure control in people with diagnosed hypertension. Periodontal disease appears to worsen blood pressure and interferes with some of the antihypertensives. The frequency of potential oral manifestations in patients with hypertension was significantly high, showing an association between gingival and periopathology in hypertensive patients. Next slide. When we look at mental health disparities, the disparities are even more pronounced. If you look at the far left, compared to non-veterans, which is the lighter blue color, veterans have more than twice the prevalence of clinical depression, almost twice as high with regard to any mental illness. And women veterans have a 1.9% higher rate of suicidal ideation compared to men having suicidal thoughts, and much higher than non-veterans. Next slide, please. So when we talk about depression, depression has an adverse effect, obviously, on oral health. Adults with depression report brushing and flossing their teeth less often than those without depression. Adults with any mental health issue are more likely to have one or more unmet oral health needs and are less likely to seek care than those who have better mental health. Depression's linked to higher levels of dental caries. And we know, as far as pain, scores on measures of depression are higher in individuals with temporomandibular disorder, chronic pain in the face and jaw, compared to those without a temporomandibular disorder. Next slide, please. There are some other chronic conditions that are significantly different. So with regard to hearing, and especially with our armed services, we see this. Those who have served are nearly 4 times more likely to have severe hearing impairment than non-veteran civilians. So 14.1% of all veterans have some type of severe hearing impairment. Traumatic brain injuries have really become much more prevalent with veterans, especially combat veterans. But between 2000 and 2019, nearly 414,000 traumatic brain injuries were reported among U.S. service members. And I'll make the link between some of these things and some of the other comorbidities in a moment. Also, adults, adults 26 to 34 who have served have 2.6% or 2.6 times the rate of chronic pain as those who have not served, chronic pain anywhere in the body. Next slide now. So I want to mention cognitive disorders, because as our veterans age, we're going to see more and more cases of dementia. And this is a really busy line graph here, but basically what it's saying is those with dementia have a marked decrease in dental care utilization. So before their diagnosis, they come to the dentist and seek care, but the moment they are diagnosed with dementia, there's a dramatic decrease in accessing dental care. So we, as oral health professionals, need to realize that and engage caregivers more. Next slide, please. So another pretty prominent comorbidity that we see among veterans is substance use disorder. So if you look in the past year, veterans have a slightly higher prevalence of any substance use disorder, but over a lifetime, there's about a 10% gap, 52% compared to 42% of non-veterans. With regard to alcohol use disorder, you see a higher prevalence in veterans. Tobacco use, a higher prevalence. Cannabis use, a higher prevalence. Usually if you do the math, 1 to 1.5 times as much as a non-veteran. And then opioid use disorder, a slight increase in veterans compared to non-veterans. And the same with any stimulant use disorder. Next slide, please. So each of those substances that are abused have direct links to oral conditions. So alcohol predisposes people to periodontal disease and oropharyngeal cancer. Cannabis, when it's smoked without a filter, it increases inhaled smoke, which causes stomatitis, leukoedema, and periodontitis. Methamphetamine, another illegal substance, causes xerostomia, high caries, perio, clenching, bruxism, osteonecrosis of the mandible. Opioids cause salivary hypofunction, caries, burning mouth, taste impairment, etc. Cocaine, perforations of the hard palate and nasal septum, sinusitis, burns, blisters, sores, decrease in salivary pH, which of course increases the likelihood of dental caries. And then tobacco, of course, periodontitis, staining of teeth, and increased risk of oropharyngeal cancers. Next slide, please. That is it for the disparities. Stacy, do you want me to take questions now on the disparities, or?
Yeah, that would be great.
Okay.
Thank you, Dr. Ricks.
Sure.
So as I shared, we have happily a really big group here today. So if you could either post your question in the chat or raise your virtual hand using the reactions button at the bottom of your screen, you'll see that it says raise hand there, and then we can manage questions. And I'm happy to start off by asking if our faculty has any questions they'd like to pose to Dr. Ricks.
First, I have a question, and I apologize for any background noise you might hear. I'm really curious if you could talk a little bit more about the potential inflammation that some of these chronic disease conditions have and how it's connected to some of the oral manifestations that we see. I know that's something that we've talked about in previous seminars, and I'm curious to hear your take on how whole body inflammation and some of these factors that we see with physical health conditions impact the oral health pieces.
Yeah, great question, Annalise. And, you know, I think you answered it partly in the question, and that is probably the key component of the relationship between oral disease and systemic disease is inflammation. So it's all these inflammatory mediators that have an impact on oral health, just like with periodontal disease, especially periodontitis, the inflammatory factors in periodontitis affect systemic health. So it's a bidirectional relationship, certainly. And take, for instance, diabetes. We know that patients with periodontitis have poor glycemic control, but we also know that patients with diabetes have more problems in maintaining their periodontium. So it's a bidirectional relationship, certainly. But then inflammation is the common denominator with oral disease and systemic disease. Does that answer your question?
And Dr. Ricks, would you say it's fair that managing inflammation should be like a primary concern among both of those care teams?
Absolutely. And that's why, especially when we're talking to oral health professionals, we say, remove the inflammation, treat the periodontal disease, and it will improve systemic health. There's plenty of research to show that successfully treating periodontitis will reduce or improve glycemic control, and it reduces complications such as cardiovascular disease, MIs, and kidney problems as well.
Thank you. Dr. Nidhi Gupta has a question in the chat asking about what are the reasons for the disparities that you shared today?
I mean, some of the disparities seem to be pretty evident. For example, hearing loss, I think, is often related to what many of our veterans, the work environment that they have, the artillery and, weapons and so forth, and of course, combat. Some of them, I think, are related to the stress of being in uniformed service, especially combat veterans, when we're talking about things like hypertension and cardiovascular disease. And I think, some of that plus, higher rates of smoking and things like that lead to asthma and COPD and things like that. So I think some of them you can just kind of deduce where the disparity originated. Substance use disorder, again, some of the things like opioids, you don't see a huge difference, but with alcoholism and tobacco use, you see higher rates. And again, I think that is stress and coping with service-related issues. And again, if they're experiencing more chronic pain, they're seeking and having mental health issues, they're seeking coping mechanisms as well. Hope that answers that.
Thank you. Carol Furch, I see you have your electronic hand raised.
Hi, thank you. I was just wondering, as my role is a public health dental hygienist, and I work with a lot of veterans. And when you look at the mental health disparities, along with substance abuse, and that often going hand in hand, I just wonder. I feel like veterans are able to seek medical care much more readily than the dental care, obviously, through the VA system. Do the mental health providers in the system ever really think about recommending that the veterans seek dental care due to the medication side effects that they're being treated with, being a big factor in why they have a higher decay rate and so on and so forth? I guess, my question is there much awareness in the mental health provider world of what the meds and, conditions are doing to the oral health of our veterans, and really anybody, but
and that's a great question. And, I can't speak I'm not in the VA, so I can't speak for the VA. I would just make a general comment that I believe that there's a pretty strong disconnect between behavioral health providers and oral health providers. So as oral health professionals, I think we certainly need to make better connections educate behavioral health providers and try to establish, that referral network. And I think one thing as oral health professionals is we can't make the assumption that veterans are being screened for every type of disorder. So I think things like doing depression screenings in a dental setting, using like the patient health questionnaire, the 2-question PHQ-2, or doing a cognitive assessment in a dental setting. I think those are things that are within our wheelhouse that we could do, and then that would actually enable us to make those connections to mental health and behavioral health providers as well.
Yeah, excellent. Thank you.
Thank you.
Thank you. Lucretia.
Oh, good morning. Good afternoon. Thank you so much for having this. My name is Lucretia Parker. I am a 28-year veteran, Army veteran, and I'm glad that you're having this conversation that is duly needed and noted on several things, and I see some things in the chat. My first question to you is, with the overall statistics and the stats that you have and the data, did you have more of a breakdown when it comes to the, I know it's men and women, but also race that plays a role as well in some of your conversation and data? And then also, as far as being treated at the VA, some veterans don't use the Veterans Administration, as you know, and how are you using that and gathering that data? So I thank you for your answer, and great to be on this call.
Well, thank you very much, Lucretia, and thank you for your service to our country. I think you're right. Not all veterans use the VA. And when I was researching the data, and I do have, the slides are going to be made available, so you'll see the links on each slide, the reference. I did not see it broken down by race and ethnicity, and I'm not sure where to find those data, but I agree with you that I think things like race, ethnicity, geography, geographic region, income level, all of those things have to be taken into consideration for sure. So yeah, and the data I have is not from the VA itself. It's from different sources, national health statistic reports and so forth. So thank you for your question. Thank you for your service.
And to follow that, when you were talking about the overall, as far as the prior question with mental health, and also with the dentist or the dental clinic in itself, one thing that we are trying to advocate for our women veterans is to have the questionnaire. And so just that in itself will probably increase for both ends, because there are 2 ends of the spectrum, to try to collaborate together, and also the medication that's taken, how it's affect the oral health in itself, because when we talk in the VA hospital about the total health, they don't mention oral health, and which that's the absence of it. And so again, this is a great conversation. Each one teach one in itself. And we were talking about total health. I think the first thing is, you go with the mouth, and everything else will come in alignment. So thank you again.
Yeah, thank you. Very good point.
Great, thank you both. So 2 questions in the chat that are related that I'm going to pose here. One is, Dr. Ricks, if you could explain the typical dental access path for veterans, and related to that, are veterans with chronic diseases eligible for dental care if that care would improve their chronic disease state?
So the last question, and that's really a question for the VA, but I believe that you have to be 100% disability, have a 100% disability rating in order to receive care with the VA dental program. regardless of whether you have chronic conditions or not. Somebody from the VA can correct me if I'm wrong on that. So what was the other part? Oh, access. I will say that, and I'm assuming you're talking about non-VA access to dental care. And I think, there's some programs out there. AIDPH has done an excellent job in capturing some of the best practices, some of the special initiatives done by dental schools, FQHCs, nonprofits, and others to increase access to veterans. The American Dental Association has this Give Vets a Smile program, and they are trying to look at ways to improve access to care for veterans as well. So I know there are a lot of things going on. Veteran oral health care is becoming more and more of a priority in the U.S.
Thank you. Another question around your comment on the cognitive disorders data slide and engaging more with caregivers. Would you talk about ideas for getting those conversations to happen?
Yeah, absolutely. So I work in the Indian Health Service, and I'll bring in our we just completed a project on cognitive assessments of patients. And it's to begin with, it's kind of a strange bedfellow for an oral health professional to do a cognitive screening on a patient, because you would think that patients would be adverse to having that done. But actually, more and more research has shown that patients, when an oral health professional looks at the whole body and does depression screenings and blood pressures and substance abuse screenings and a cognitive assessment, patients are very accepting of that when we look at something besides just the mouth. So but we used a special cognitive assessment called the MiniCog, MINI-COG, and you can Google that. But the MiniCog, there are videos that show how it's used. I mean, like a provider talking to a patient. It's really easy. It only takes about 5 minutes or so. And it's not done on every single patient. When you have a patient sitting in the chair that is non-compliant and you can't figure out exactly why, or they don't seem to be able to repeat instructions that you give them, when you know something is off, that's when you might want to do a cognitive assessment. And then if there is, after you, there's a scoring mechanism with the MiniCog, and if they score such that they need to be referred, then that gives you a great opportunity to make that connection to a primary care provider. And then, if they are in the early stages of some type of cognitive impairment, that's when you as an oral health professional can engage not only them, you don't omit the patient, but also try to encourage a caregiver to start assuming some of the oral health caregiving as well.
Thank you. We're going to take our last question and then move to the case-based learning part. Herb Silva.
I'm a dumb Marine here. I had to figure out how to get the audio working. Spent 10 years in the Marine Corps as a helicopter pilot before I went to dental school. Squadron I flew with in Nam, 4 of us became dentists. Go figure. After 38 years in private practice, I've been teaching at a dental school for the last 7 years, where we've initiated veterans treatment as part of the students' 3rd and 4th year requirements for graduates. Students need to do procedures, veterans need to whatever. We do free screenings. We've connected with, this is, again, we have to come up with ways to get into the community of the veterans. 85% are not eligible for treatment. Of the 15% that are eligible, only or less than half of them go and get treatment. So, here we do a comprehensive screening exam with our vets. We're getting ready to do free screening we've already got 100 vets signed up for after the 4th of July. But that's a model that can be worked around the country. There are dental schools all over the country, all those students need those PROS requirements, and that's something, it's an avenue that can be explored. Just making that point of evaluation.
Thank you for sharing that.
Yeah, thank you, and thank you for your service. And I think there's each of us can try to look at local resources like Disabled American Veterans, American Legion, to try to find veterans. If we're interested in providing care, they may be good referral starting points.
Great. Thank you. Thank you, Dr. Ricks, again.
Thank you, Stacy.
Okay, Annalise, if you'll take us back to the slides. Great. So now for the applied interactive learning part of today's call. And the purpose of this part of our call, as it is each month, is applying knowledge through interaction. We're going to talk about clinical solutions that can be personalized to your organization, stimulate integrated and value-based design activities, and understand opportunities within a complex health system. And we hope that you'll engage in peer learning and interprofessional collaboration that you can take beyond this call. So here's how this is going to work. Everyone is going to be assigned a breakout room. The caveat to that is 1/3 of you are actually going to stay in the main room, so you won't see an invitation pop up on your screen to go to a breakout room. You're going to stay here with me. Every room is going to have a facilitator, and each person in the room is going to be asked to complete an electronic notes form with their answers to the discussion questions. And you will receive a copy of your responses via email after this call. Liz has posted a link to that Google Doc, to that Google form in the chat. And when we come back from the breakouts, we're going to come back to the main room and we're going to ask one person from each room to report out on the discussion. So please identify that one person in your room as you get started. Next slide. So here is the case that we're going to ask you to consider. Samantha is a 35-year-old combat veteran with PTSD who presents to her dentist with complaints of bleeding gums and tooth sensitivity. She has not visited a dentist since she separated from active duty more than 10 years ago due to dental fears and exposure to trauma. She has a past medical history significant for type 2 diabetes, hypertension, and depression. Samantha reports difficulty managing her blood sugar levels and often forgets to take her medication. She also reports experiencing symptoms of anxiety and depression, including difficulty sleeping and loss of interest in activities she used to enjoy. Samantha has 3 children whom she cares for alone and has limited access to healthy foods due to financial constraints. Next slide, please. So here are the questions that we're going to ask you to consider in your breakout rooms, and you'll be able to see all the questions. They're posted in the chat right now, and you can also see them in the Google form. What questions should medical providers and dental providers be asking the patient and each other in order to assess physical, mental, and social drivers of outcomes? 2, what are some effective strategies for interprofessional communication and coordination of care between medical and dental providers to address the complex health needs of veterans with diabetes? 3, how can dental teams incorporate screenings and preventive services for chronic disease management, like hypertension and cholesterol monitoring, into their routine care for patients with diabetes? And lastly, how can dental teams and medical teams apply effective risk assessments and treatment planning for social, physical, and mental drivers of health for Samantha? So again, we're going to ask each of you to complete a Google form with your reflections on this, and your facilitator is going to walk you through discussion of each that we can get to while in your breakout rooms or in this main room. And once you get to your rooms, you're going to have 10 minutes. So we'll be touching on these a little bit lightly, but we hope to get as deep as we can. So once you get to your rooms, it'll be 41 minutes after the hour. We're going to bring you back at 51 minutes after the hour to share out. Any questions? Okay, Liz, send them away. Okay. Everyone's still moving around a bit. Okay, I'm going to ask if you're in a place that you're able to be on camera, we'll ask that you please turn your camera on. We always find that makes a huge difference when we're trying to have discussion for folks to see one another. Thank you to Christine, to Herb, to Jean for doing so and for setting an example for others. So please grab, if you haven't already, the Google form link that's in the chat. And you don't have to complete the whole survey, the whole form while you're on today's call. You can submit it afterward, but we're hoping that you'll complete as much as possible while you're here. It's a great way for us to collect information, which will then inform future sessions of this program, as well as what follows the full collaborative series. So the first question here is, what questions should medical providers and dental providers be asking the patient and each other in order to assess physical, mental, and social drivers of outcomes? I mean, that's a pretty broad question, but what are some things that come to mind when we think about veterans with chronic illness?
How are you feeling today? Did you have your
Ooh, Mutahara, you cut out a little bit. We heard, how are you feeling today? And then we lost you.
Can you hear me now?
Barely. And you can also feel free to enter your answers in the chat.
Hey, this is Lanetra. I think it'll be good to, and I'm sorry I can't be on camera. I'm not in a place where I can, but I think it'll be a good idea to definitely get a detailed medication list and then ask questions about those medications. Like, are you taking them regularly? How often? And maybe, do you feel any side effects from the medications? I would start with health history. So, asking a lot of questions about, those type of things, just, outside of the dental complaint, but starting with health history first. And like the first representative said, asking how are they doing today, those types of questions too.
Thank you. Those are great. Other thoughts?
Yeah, this is Silva. So at some point, again, I've got my dental school hat on. We're going to start with an interview and a medical history, and as part of that is going to be a detailed medication list. One of the questions: how can I help you today? Why are you coming to see me? What can I do for you? And then you get a background on where it's going. This patient in our environment I live in St. Louis. The school's in St. Louis. And so we're drawing patients from the rural areas as well, which of course is the transportation as well. Do you have access? Typically, this 35-year veteran with post-traumatic stress is going to have access to a VA. Do you have access to the VA? Do you use it? Then we're going to look for a medical consult type of thing as to what we're going to be doing proceeding. I got my dental hat on first. We're going to do a full dental exam as part of this comprehensive thing, and then ease into the other stuff. And we found that it starts with that, and we show them what we can do for them, and it goes from there.
Great, thank you. Yes, Jean.
And to just elaborate on that, exactly, medical clearances perhaps for special, for hypertension or uncontrolled diabetes, things like that. That's where that interprofessional relationship will come in.
Great. Yep. And that's a great segue to the next question. What are some effective strategies for interprofessional communication and coordination of care between medical and dental providers to address the complex health needs of veterans with diabetes or other conditions? Anyone like to build on what Jean started there?
We're going to get their blood pressure, but we're not going to get their A1C type of thing in the dental office. And so that's going to be, again, they've got to connect with a lot of the patients that we find. I mean, we have to find the patients that have chronic problems but are not aware of it. They're not aware the blood pressure is off the chart, or they're not aware of what their blood sugar is, type of thing. And they don't pay attention to the thing. Of course, this gets into the nutrition. She doesn't eat, she doesn't have access to food, and so forth. It's a big circle as to where that plays on out.
And I know you're not Christine Cody, and I'm who put the comment in the chat, another doctor who's in for her, but she shared we're starting team-based care at our FQHC, which includes a behavioral specialist and an MD. I would consult with them. Dr. Gupta, thank you. I thought that was your name and I wasn't 100% sure. Thank you.
And I would build on what Dr. Silva said, point of care testing, like A1C. I mean, I work in a school, in a dental hygiene school, and we actually ask that on their medical history. We do ask for it, but point of care, like we take blood pressure, but again, I'm in a school setting. So it would be lovely to get all this, what we teach, to actually happen when they get into practice.
And so what about the next question? How can dental teams incorporate screenings and preventive services for chronic disease management, like hypertension and cholesterol monitoring, into routine care for patients with diabetes? Any thoughts on that? Maybe someone we haven't heard from yet who has their camera off. Or someone we have heard from already.
Easy to get blood pressure. After that, you've got to have a health setting type of thing. Typically, even in a dental office, you're not going to have them draw blood and usually and go from there. So if you're in an FQHC setting, potentially they're going to have part of their health services. Again, if you've got a connection, what's the distance to the VA? And we can send medical consults to the VA saying, hey, we need this information and so forth before we can proceed with what it is that we're trying to do from a dental perspective.
Great. And Dr. Gupta shared, we check blood glucose levels for diabetic patients and have access to A1C levels under labs as the software is integrated with medical. That's great. And for those of you who aren't able to come off mute or to put your cameras on, please, we hope that you'll still submit your ideas in the Google form. We'd love to have that captured. And then finally, how can dental teams and medical teams apply effective risk assessments and treatment planning for social, physical, and mental drivers of health for patients like Samantha?
Health fairs, where you do these screenings. Yeah.
Hi, this is Lanetra again. I was going to mention maybe in private practice, partnering with the dental programs with the State Department of Health. Usually they have resources. I used to work for a State Department of Health, but they typically have, I'm in the state of Mississippi. So we used to have a program with diabetes, like a self-management education course that patients can participate in for free, and things like that. So maybe partnering with those type of programs will also help private practice to be able to implement some things and develop some policies and procedures that they could put into their private practice.
These are all great ideas.
Well, there's simple things. Again, in any dental office, we can do a caries risk assessment, and that's easily accessible. And a lot of times it's educating the patient as to the correlation between what it is that they're eating or not eating and the contribution that that's doing to their dental problem type of thing. You get into the substance abuse patients, and they're having Mountain Dew for breakfast. And so that's the hassle of what it is from an educational standpoint. So there's nutritional counseling, educational stuff that we can do with their diet that's easy to do in any dental environment.
Yeah. So we're just about at the end of our time. I wonder, Herb, Sheen, or Lanetra, would one of you be willing to share out when everyone's back? Herb, is that a raising your hand, or is that a not me?
That's, I've been talking too much. I'll let somebody else summarize. Thanks for listening.
And thanks for everyone is flying back here through cyberspace. Great. Liz, can we tell if everyone is back? Okay, here we go.
It looks like everyone has come back, I think.
Great. Thank you, everyone. Welcome back. I hope your conversations were fruitful. I want to just say before we do some report outs, if you did not get a chance to speak on your call, or even if you did, please complete the Google form for us by the end of day tomorrow. We would love to get your ideas and input to inform how we move forward with this collaborative and the programming that comes after it. So thank you for just taking a few minutes to do that. So I know we had great conversation in our group, and I wonder if anyone would like to share out some of the answers. Many of the answers carried over across the questions. Jean, I think I see your hand going up. I'm going to ask if you come. I think you can just share some.
No, actually, I don't know. I wasn't raising my hand, but okay.
Go ahead. Thank you.
So, okay, so the answer to the first question, I believe we will all agreeing with a detailed medical history, health history, including medications and how often they're taken, do they take them? But a detailed health history is very, very important. Are we gonna do this question by question, or how do we?
Just, you can offer some reflections on any of the questions, some things that stood out for you from our group, including anything that you shared.
Okay. So then it sort of led into talking about as far as interprofessional meeting with or being in touch with the medical professionals about a patient's chronic condition, such as an uncontrolled diabetes, making sure, or blood pressure, hypertension, getting a clearance for having dental work done. I see somebody has their hand raised. Maybe they want to add something.
Oh, sorry, Jean. I was in a different group than you, but I raised my hand preemptively to speak to it. If you have further things to add, please go ahead.
I'm good. I'd love to hear from you.
Thank you, Frances. We appreciate that.
Yeah, I think Stacy may know me from a couple other groups. She knows I'm happy to talk whenever I get a chance. And so just one of the things that my group was discussing, we addressed the questions, and all of us who spoke to them were getting into discussions about infrastructure, policy, and training. We heard from a couple of clinicians who talked about how important it is to have that understanding of oral health care in the medical facilities that are admitting individuals who have ongoing oral health conditions. And as we know, dental professionals are trained as pre-med, essentially pre-med providers for over a year. And we don't necessarily see that same emphasis in oral health in some of our other health disciplines. And then I talked a lot, no surprise probably in that group, about integration of care. I worked at a community health center, and I see how public health is really, really able to integrate in terms of infrastructure, trainings for their staff, and forms for patients that are addressing these individual issues and bringing them together. Like you mentioned, Jean, in that health history, like there's so much that can be done with that. And my takeaway from the group personally, I work in a state program, and I really feel for the amount of effort that our oral health workforce goes to try and integrate care and to provide care. And I want to do at my level at the state to do what I can to provide templates, toolkits, some of the resources like that the ADA makes available to help professionals to integrate these steps into their workplace without having to do all of that legwork themselves.
Thank you, Frances. And we have time for a brief report out from Lucretia from the final group.
Okay, well, our group is awesome, but we were at roundabout with everybody throwing everything in, which is really great, and also those who haven't spoken. Just to the VA and also the Veterans Center might be a great avenue that you might want to have resources to collaborate with. Some patients, especially women and men, with they have military sexual trauma as well, and so that might be another indicator to kind of go easy in different phases for them, that one appointment might not be like the next appointment, so have patience. And then if that's the case, to have a questionnaire as well with the patient or the veteran, being in a safe space and making them feel comfortable enough to open up, and changing doctors or dentists, it might be concerning to them as well as veterans, and also having that oral health screening by the doctor, not just the dentist, but the medical practitioner, if they had that questionnaire of cancer screening or whatnot, might carry it with them, because we love to have our records with this in hand. And so those are the different stages. So thank you so much.
Thank you. That was terrific. Annalise, if you'll take us back to the slides. Great. So we want to flag our next two sessions are the topics are listed here, and you can also find information about them on the AIDPH website. And I'm going to turn it over to Annalise to talk about our sign-on letter.
So much, Stacy. I appreciate everybody's interaction today. And I saw a lot of commitment and interest in improving veteran oral health. And we wanted to signal that there is a very specific and actionable opportunity to do that. Again, I apologize for any background noise you may hear. AIDPH has been circulating a sign-on letter for veteran oral health to improve and expand access to dental care through the VA. There are actually multiple bills right now that have been offered of varying increments that expand eligibility to veterans with chronic disease conditions like heart disease and diabetes. I fully believe that these bills have the ability to gain momentum, but we need to signal that there is support among the veteran and oral health community to see those through. So in the chat, you'll find a copy of the sign-on letter, and you will also find a copy of the form to sign on to that letter. We are soliciting both individual and organizational signatures. So even if you can't sign your organization, you as an individual can always support this letter. So we hope that you'll take the time to sign on. It goes really quickly. And please pay attention, because there will be more calls to action for advocacy around this specific topic if you're interested.
Great. Thank you, Annalise. So I want to thank everyone for joining us today. Thank you again to Dr. Tim Ricks for presenting. Thank you again to CareQuest Institute for Oral Health for being our partner in this project. And Annalise, if you'll take us to the next slide. We are at the end. So thanks all for bringing your great questions, your engagement, and your passion for this work and this topic. Please reach out to us with any questions, and we look forward to seeing you next month. Take care, everybody.